Labormed atua no mercado nacional de videoendoscopia digestiva e cirúrgica desde 1988. Trabalhamos com atendimento de qualidade na comercialização, distribuição e pós-venda de nossos produtos. Contamos com uma rede moderna e bem equipada de assistências técnicas espalhadas por todo o Brasil. Além disso, somos a única empresa certificada para atuar no reparo e assistência de equipamentos Fujifilm. Labormed. Entre em contato conosco.
Fujifilm has pursued and developed cutting-edge image processing technologies over the past 70 years. And in 2018, utilizing such technologies, it developed medical AI technology. And for endoscopy, Cat-Eye powered by Riley. This novel function is specifically designed for evolving Eluxio with two functions to support endoscopic diagnosis. The first is detection support, and the second is characterization support. Riley provides new possibilities for diagnosis with LCI and BLI, developed by Fujifilm. The user-friendly interface has been developed to enable comfortable procedures. It does not interfere with clinical images and minimizes required eye movement. Its display is designed to be simple and intuitive. Operation is seamless thanks to automatic activation when switching image enhancement. Fujifilm continuously evolves Riley to create new visions. Accelerate innovation. Cat-Eye powered by Riley. Fujifilm.
Good evening, everyone. It's a great honor to welcome all of you here, the speakers, the moderators, and also our listeners. I'd like to thank, first of all, this is our second international meeting for digestive endoscopy. And this is a course that has been becoming an important event in the national international scenario. That is why we count on the support of Ssld on behalf of Ricardo Gibi, Ssld, and Professor Ssld representing ABM, and other than ABM, the Federation, Gastric Brazilian Federation, Professor Dissection, and the support of the regional chapters. It would not be possible to hold this event without the support of our diamond sponsors. That was Labormed, Fujifilm, and the gold one, which was Boston and EMS. Beyond that, and not less important, we had the support of Imalac, Promedon, and also Aspen. I would like to thank everyone, and we are going to continue with our program. And now I would yield the floor to Professor Isomar. Before that, we'll have a video, and after that, we'll have Professor Isomar, who's going to say a few words. Good evening to everyone.
A ciência expande os horizontes do
Science
homem.
expands
A Boston
the
Scientific
horizons
transforma
of man.
vidas,
Boston Scientific
salvando pessoas
transforms
com
lives,
conhecimento
saving
e inovação.
people and bringing
É esse o
innovation
princípio
and
que
knowledge.
inspira
This
nossos
is
30
what
mil
inspires
colaboradores
us,
espalhados
our
pelo mundo,
30,000
para melhorar a saúde de
collaborators
30
to
milhões de
improve
pessoas
the
em
health of
120
30
países
million
todos os
people
anos.
in
O Brasil
120
cedia a única
countries every
fábrica
year.
da
We
Boston
have the
Scientific
only
no hemisfério sul,
factory
que
in
acompanha as
the
inovações
Southern
que
Hemisphere,
curam e
which
tratam
follow
com
the
respeito,
innovation that cure
eficiência e
and
carinho
treat
em
with
6
efficiency and care 6 specialties:
neuromodulação, cardiologia
neuromodulation,
e intervencionista,
interventionist
urologia e saúde
cardiology,
pélvica,
urology
intervenção
and pelvic
periférica,
health,
controle do ritmo
control of
cardíaco
cardiac
e
rate
endoscopia.
and endoscopy.
Continuamos
We'll
inovando com os
continue
mesmos valores
innovating with
éticos e
the
a mesma
same
responsabilidade
ethic
que há
values
40
and the
anos nos
same
inspiram para fazer mais e
responsibility
melhor. Boston
in
Scientific,
the
transformando
last 40
vidas
years,
e deixando
transforming
marcas.
lives and leaving our traces.
Fundada em
Founded in
1964, a
1964,
EMS está presente em mais de 40 países, com mais de 80 patentes ao redor do mundo. É a terceira maior indústria farmacêutica da América Latina e líder do mercado farmacêutico brasileiro há mais de 10 anos consecutivos. Tem o maior portfólio do Brasil, atendendo mais de 1.000 patologias e tratando 25 milhões de brasileiros por mês. Os medicamentos produzidos pela EMS são exportados para mais de 40 países, entre eles a Inglaterra e a Alemanha, que seguem uma das legislações sanitárias mais exigentes. São mais de 80 patentes próprias concedidas pelo mundo, incluindo Brasil, países da Europa e Estados Unidos. O que você conheceu aqui hoje demonstra o nosso compromisso de inovar e aprimorar tudo o que fazemos, buscar constantemente o mais alto grau de eficiência, atuar com ética e seriedade em todas as nossas atividades. Tudo isso para oferecer a melhor solução de tratamento aos pacientes. Isso faz toda a diferença para nós. Mas nosso encontro não acaba por aqui não. Vejo você no futuro.
Professor Jomar, who's the technical coordinator of the memorial, is going to talk briefly about the seminar and about our institution. Professor Jomar, you have the floor.
Boa noite a todos.
Good evening, everyone. It's a great pleasure to be participating in this second international meeting for endoscopy. The Memorial Itaigara Memorial, as always, is an institution who does all it can to improve the quality of endoscopic treatment, always concerned about improving the image, treatment, and diagnostic, and also participating at the national level of many events. It's a great pleasure, and I'd like to thank its board of directors of Memorial Itaigara, who has always bringing us the best, always trying to bring science in first place. I'm sure that it will be a very profitous night and a very interesting night, and I'd like to thank our colleagues, national and international, who have been named by Dr. Rodrigo, great endoscopists, and I'm sure that it's going to be a very profitous night. I'd like to greet our friends, international friends, Professor Ssld, who is going to talk about the best in terms of the knowledge that there is available. I also thank the organizing committee, Dr. Rodrigo Luiz Felipe, who relentlessly fights for this purpose, and wish you all a great meeting, and we hope we'll learn a lot and discuss a lot. That's why we are all here participating in this group, our colleagues who are patiently listening to us. So I thank you all, and I hope you all have a great course. The first part of the lesson will be presented, the first lesson by Dr. Luiz Maruta, Endoscopy through Advanced Diagnostic. Dr. Luiz Maruta is the head of the University Hospital of São Paulo, followed by Nelson Miyajima, talking about endoscopic treatment of superficial gastric lesions, mucosaectomy versus Ssld, EMR versus Ssld. He is a doctor of the endoscopic service of the clinical hospital of USP. And then we'll have 4 people participating in the debate. Dr. Vitor Rossi from the Itaigara Memorial Day Hospital, Dr. Marcos Clarencio, who is the coordinator of Roberto Santos, Dr. Daniel Lira, who's an endoscopist doctor for the Memorial Day Hospital, and Carlos Hobbs Jara, who's the director of the Equatorial Institute of Digestive Disease in Ecuador. It's a great honor, and I yield the floor to... Before that, we'll have 3 videos, and then the word to Luis Maruta.
The story of Microtech, which originated with stents, is about sustaining life. Microtech, your trusted partner.
Melhores resultados vêm das melhores escolhas. E Probid é a melhor escolha entre os probióticos. Probid tem a exclusiva tecnologia Biosuporte, que garante a resistência das cepas ao ácido gástrico, entregando-as vivas ao intestino. É o primeiro probiótico com alegação funcional aprovada para auxiliar na redução de complicações gastrointestinais, dor abdominal, náusea e vômito. Além de ser o único com atuação no eixo cérebro-intestino, comprovada por estudos clínicos, auxiliando no alívio a sintomas gastrointestinais relacionados ao estresse. Equilíbrio e bem-estar para uma vida mais saudável. Probid, único com atuação no eixo cérebro-intestino.
Eu sou Iane Moraes, sou enfermeira do Centro Cirúrgico de Itaigara
I'm a
Memorial
nurse of the
Hospital.
surgical center of Itaigara Memorial. My father is also a nurse. Every day at night, I used to see him studying. This fascinated me, making me very interested in knowing how one day I could contribute to help my neighbor. My name is Lúcia da Silva Figueiredo. I'm a nurse at the surgical center, and I'm a technician. I love my profession. It's a profession that makes me grow as a human being, and every day I'm a better person for me and for others, and for the world, and for my patients, and for the institution. My relationship as a professional with the patients is to know that every day when I wake up, when the day starts, I will be able to contribute in some way. We'll leave our families, and here we take care of another family, many times an unknown family, and we offer the best of us. And this is, for me, it's very gratifying. My relationship with my patient, I could say, that is a unique and the first professionalism, companionship, and love to my neighbor. Thank you very much. You are the best, and I love you. And these are the sentences that we hear every day. God bless you. It's so good to hear this. God bless you. We sometimes feel our heart beating stronger and hoping to hear this the next day. Itaigara Memorial makes us to feel valued. And we are heard, our ideas. So as I said, we get here many times in pieces, but we breathe in and we say, I have to be full, because we need to give our best. And the best that we are giving, these are people who trust us. So looking for a handshake, looking for a smile in our faces, and with an attentive look, with a focus of attention and a lot of respect to pain. I do feel gratified to be in this profession.
Itaigara
Memorial is this, in constant evolution, from its physical facilities, state-of-the-art equipment, and a united team that is a very welcoming and modern hospital. This is something that I do not know anything like it. We make Itaigara Memorial, a hospital made of people who love what we do. Thank you very much. Professor Luis Maruta, we can start our lesson now, your lesson now. Please, thank you. Could you start? Thank you very much for your presence. We don't have his audio. Okay, good evening, everyone. I thank very much the organizing committee. It's a great honor to be here. We are among friends, so I'm going to present my lecture, and I'd like to introduce my experience regarding advanced technology. I'm going to share my screen. I have been working with this technology for a few years, so I would like to share my experience here. I think this could be important for many endoscopists, especially those who are starting their career. I studied endoscopy in the 70s, in the 80s, and I always studied gastric cancer, but I believe that the technology, advanced technology, has helped me and has taken us closer to the Japanese school regarding the diagnostic. So what is important if you want to have a good quality of an exam? It depends on the quality of the monitor, the resolution of the image, the intensity of the light source, and also the contrast. So this image here shows what is a high-resolution image. Even if you expand the image, the amplification, maximum amplification of the image, you still can see these small alterations, even if you expand them a lot. So for that, we have to have excellent light. If I compare this to another image here, with a camera that is a cell phone camera, we can see that when we expand, we amplify the image just a little bit. You are not able to visualize the definition of image. So the technologies that we have available to us today, from the Fujifilm, was FICE at the beginning, which is the decomposition of light and the images and colors, and the recomposition according to your choice. You can get the ideal recomposition as you wish. In Professor Yamamoto's school in Jichi, we have all of these FICE definition from different doctors that use these definitions, each one as they wish. What is important to say is that there are doctors of other schools that still use the 5 standardization. So I'm sharing with you, and you can see the resolution that is used in Japan. The Olympus technology is the Nbi. Also consists on the decompositioning of light, but through the use of filters. It produces, he says, just a second, an alteration which makes it possible to have a very clear definition of hemoglobin, which are inside the blood vessels. The big problem of both technologies was the low light source. These technologies have been improved with the new equipment available. So that is from Olympus, brighter, with better imaging, more clear light, and lighter images, and Fujifilm that has added laser or LED. So when you activate the electronic chromoscopy, we have a very clear visualization possibility of the vessels which are contained inside of the lesions. Other than this, the mix of image would allow you to visualize the alteration, the superficial alteration, the microstructures of the mucosa. The LCI function consists on a digital transformation of the image of the white light, as if it would be a face, but now using the technology with the laser LED lighting. Here I have an example of the advantage of the use of the LCI technology, which makes it easier to visualize edematous lesions. This is a technology that is here to improve endoscopy procedures, and the question, the most obvious one, is if it would be worth investing in this technology, these new technologies. I'm going to show you an exam that I did in 2010. This is the exam with white light, with indigo carmine. So this is a lesion. This is an alteration here with this irregularity in incisura angularis. This is a irregularity. It could a scar. It could be many things. But we have to have the biopsy of the lesion to have a precise diagnostic result. This was the reality before we had this new technology. Now with a click on the button, you can see this type of alteration. This is a microvascular alteration. The disappearance of the microstructure and the lines and the limitations and markings. And then you change completely your type of exam. This is a cancer, and I can guide the biopsy to this point here. I have no doubt that it would be a cancer. Another case that according to conventional endoscopy, we could diagnose as an erosion in the posterior wall of corpus to be clarified. It could be a cancer, it could be an erosion, it could be an inflammatory process, anything. But with a touch of the device, we changed the diagnosis. It's a cancer which had the appearance of an erosion. This was done in 2010 and 11 in such a way that, in theory, it would be a different kind of exam, and now we are dependent on this technology. Before I get to the stomach lesion, I'm going to show you a case where this is used in Barrett's esophagus. This is a case from Hasegawa. This is the lesion with LCI. And here we can see that there are areas where conserved structure of Barrett's and others with the disappearance of the Barrett's structure. This is the result with a better picture. And see, you have normal structure and discretely altered, and others with a structure that is absent or disform, and the presence of microvascular alterations. This is an exam that is much more effective in Barrett's segment. So let's get now to stomach superficial lesions. How do I do this exam if it's so hard to use magnification? So the first evaluation that I make, it's the type of the atrophic alteration that I try to standardize by using the classification of Kimura-Takemoto's. We know that this gastric atrophy, it goes from the antrum and goes toward the gastric corpus with this curve and to the posterior and anterior progressing. And we can have type C1, which is the atrophy. We can see the line before, and the C2 there would be after the angularis and seizure. With little training, you're able to see the area of the atrophy. This is the open type. The atrophy goes all the way here. You see the whole curvature, the antrum, and goes in the small one. The type O1 that is open and the atrophy. And the O2, including the anterior faces, but not completely the stomach. And the type O3 of atrophy when it's total one of all the walls. Why do I use this classification? Because the papers, the Japanese papers and Masoyama show that the open types of atrophy like O1, O2, and O3 show high incidence of gastric cancer. So in the type O3, in this casuistic of Masoyama, and he has found 160 cancers in 3,004 cases of O3. So this gives us a percentage of 5.33% of incidence of cancer when you find an atrophy type open type 3. So this it goes also for O2, 3.70%. O1 is 132%. So starting from the types C0, C1, and C2, the incidence of cancer is very low. So we can, through this subdivision, this classification, using this classification, we can guide in which cases we're able to have put our efforts of using these new technologies to find gastric cancer. Why to use them? And I'm going to show you this case in the normal standards with white light. When you have this atrophic gastritis, you have to pay attention to every alteration. But with white, you could have a biopsy of this ulcer with this hemoedema, with this area with irregularity, and biopsy this angularis insidious in such a way that you would have to have multiple biopsies, and you would not have certitude. With magnification of image, with electronic colmoscopy, we can identify one area. And hypochromic with microvascular alteration, and that had nothing to do with the areas which presented alterations of scars. This is an area that is a healthier one with hypochromia, showing you the use of this technology of advanced endoscopy imaging to understand better this type of lesion. This is another case of gastric atrophy with O3. There you have to have a perfect exam, preferably using technology, and this is a gastric fundus, early GC, 2C with white light. But with the use of technology, you have the certitude that you're really dealing with cancer. The absence of microstructure and the microvascular structure that is very extensive in this lesion. So you do the diagnostic of gastric cancer. How do we do this? For sure, Professor Yao teaches from Japan, for you to establish a diagnostic, endoscopic diagnostic, you have three parameters that you can use. You have this line, the microvascular alteration that you can see in this area to be studied, and the microstructure alteration. In this case, there is the disappearance of this microstructure. So this microstructure alteration is present because it has disappeared. You see the microstructure that is completely visible, and this is the line of separation. So this is the algorithm that is proposed by the Professor Yao, for the diagnosis of gastric cancer. So we look at this, trying to find a suspicious lesion. You should try to have a DL. If it's present, if there is a persistence, you still have the suspicion. If it's absent, it's non-cancer. If the DL is present, then you can see if there is microvascular or microstructural. If it's present, then it's cancer. So here we have examples of microstructure alterations. I'm going to be talking about this, a differentiated cancer, and is characterized by this microstructure. And undifferentiated is characterized by microvascular. So this is very clear, the microvascular and the DL that is very visible. Now the diagnosis of cancer has been set. We also have some other alterations which might be used as markers for gastric cancer. One of them is the white opaque substance. This consists on a deposit of lipids in gastric lesions, especially if they are very elevated, very much elevated. If we find this type of alteration, in 2008, Professor Yao has described that there was a relationship, high relationship with gastric adenoma or cancer. This theory was reviewed in 2017, 2018 by the same team of Dr. Yao, which has related this the white opaque substance with the presence of hypochlorite and the intestinal metaplasia. In any way, there is still the possibility that when we find this type of alteration, there is a possibility of be dealing with cancer or adenoma. Another marker, and this is an example of cancer, and the presence of this type of alteration which causes problems to microvascular study. It's visible with the Nbi or FIS or BLI. It's not visible with white light. So this is a case of this intestinal metaplasia that we can demonstrate, where we can demonstrate this white opaque substance alteration present. Another marker that we can use and describe also by the Japanese school is the white globe appearance. These are cells containing necrotic in its interior. Within the cancer, the suspicious area of cancer, if we find this whitish, harder area, this is a marker for cancer that is called the white globe appearance. So this is the work of Professor Naohiro Yoshida, showing that it's a marker for gastric cancer. This, in retrospective studies, we could identify these alterations within the area, the cancer area, suspected area. So this is another case. We can see the white global appearance as a cancer marker. We have an alteration here, and probably this is white globe appearance in underdevelopment. So how can we differentiate cancer from a diffuse type? The well-differentiated gastric cancer is mostly characterized by microstructure. We'll have a DL that is very evident as well. So according to the evolution and how much you have of differentiation, this is one diagram that is characterized by Dr. Nakamura. The formation of these glandules in the interior part of the gland. So the trend for well-differentiated is elevation. It could be depressed, but most of them have this trend to be an elevated lesion. If you have any elevated alteration, you have to take into the consideration the possibility of gastric cancer. So there are many types of alteration that are microstructure, which could be identified when they are well differentiated. So we are collecting material because there are many alterations that could be identified, but the alteration should be evident if you compare to the neighboring area, and in the altered area could not be so homogeneous. It should be heterogeneously presented. These are some cases in this incision. You see the DL in an area with microvascular that it's very well differentiated. This is another case. There is a hypochromia in the anterior wall of the incisor angularis, the presence of the white opaque substance. And we can see if you amplify besides this white opaque substance, we have an area with microvascular and microstructure. We have DL, closing the diagnosis of gastric cancer in this case, with LCI showing the DLI, showing that there are alteration DL, microstructure, and a microvascular, which is not so evident in this case, because we are dealing with a well-differentiated cancer. Another elevated lesion characterized by microstructure alteration and DL. So you can see that probably the white globe appearance in this region. How is undifferentiated cancer presented? The presence of microvascular alterations and the absence or irregularity of a microstructure. This is the typical case of undifferentiated cancer. This is the way as it propagates. It's presented in the column of the gland and infiltrates laterally, sometimes provoking disappearance of the structure above cancer. So this in there is no cancer that is undifferentiated, that is presented elevated, or they are usually depressed. So this is a cancer that is undifferentiated cancer, characterized by the absence of microstructure and the presence of microvascular structure. This is the gastric corpus covered by mucus after cleaning, and we can see the absence of microstructure and the presence of microvascular abundantly in this lesion that is very small of gastric corpus. It could come unnoticed if you do not do a good preparation for the exam. Another case, hypochromia. In reality, it was mucus. Mucus covering the lesion after washing, and the local cleaning. We have here any antenna. We could identify the cancerous area, DL, and microvascular alteration, and microstructural. Atrophic diffuse, where we can identify the cancer area in this region. It's very clear, and the exam is completely different when you use the high technology imaging in these cases of gastric cancer. These are repetitives, this image, and I'm going to go a little faster. The hypochromic and atrophic gastritis. You can study this area and to be sure about cancer, undifferentiated cancer. You have 5 minutes now. So I'm just going to close, and this is the function that I find very important, which helps us delimitation of gastric cancer. This is the standard. This is an elevated cancer lesion. When you don't use advanced technology, you could delimitate the cancer in this region. This delimitation, this initial one that we judge to be present. So it's very easy to visualize the DL line, but this case here has presented, other than this area, we had a 2B that is very flat above this area here. And we studied it a little bit better, and we showed that microstructure that is very important in this region. So the lesion was approximately marked in these areas. And there is a change in the final delimitation using the advanced technology. This is a case of undifferentiated cancer. I just would like to show this special case, and you cannot see where the cancer area is. This is with BLI and comparison of image, we can see the area, the cancer area, and the DL, that is the absence of microstructure. Here we have microstructure, but the cancer is below this area and this type of structure. So in this region here, we cannot be sure if there is cancer below this area, in such a way that when the cancer is undifferentiated, the Japanese school preconized the use of biopsy to show that the margin of this lesion is around here. You have to confirm through biopsy the area of the lesion, for sure. This is what I had to say, and I am sure that in the future, very soon, this will be part of our routine. To have at hand at least one of these equipment that could be very useful to us to use wherever you have treatment of cancer. Thank you very much, Luiz Maruta, and now I yield the floor to Professor Nelson Miyajima to talk about endoscopic treatment of superficial gastric lesions. Nelson, you have the floor. Can you see it? Yes. So good evening, everyone. Thank you for the invitation and to Itaigara Memorial for the second international seminar. It's a great pleasure to talk. It's a great responsibility with all of the people here. Professor Yoshida from Kyoto, who is one of the most prominent people in this area in diagnostic as well as in resection. Professor Carlos Robles from Ecuador, great reference in Latin America, and it's a great pleasure to be here with you. So, and talking after Dr. Luis Maruta, after this brilliant presentation, and my other colleagues, and very important endoscopists. The topic that I am supposed to talk about is mustactomy or submucosa. We're going to talk about this in a very pragmatic way according to our experience and our resources, our limitations in Brazil. And we are not discussing any therapy if we do not make a diagnosis. So I'd like very much to talk about diagnostics, even if Dr. Maruta has already talked about cases which are just exceptional. But the diagnostic can only evolve and improve in detection if we see many cases. So I like to show a few cases to improve our capability to detect. We have a high risk metaplasia, and we call the attention to identify this type of alteration with a hypochromic area, with a well-differentiated area, where we have atrophy in many different areas with hyperemia, calling the attention to this small and more elevated area, and a lot of intestinal metaplasia. So we should train our eyes. So that was white light. That's what we have today. Be able to identify this type of alteration. This is a fundamental stage. And if you have this image and you get this message, then take it home. I'll feel that I have fulfilled my mission. White light is what we have, so we have to be very attentive of in regard to the quality of our endoscopic exam. This is something I was recording to show how I do my daily exam, and I was surprised with a small lesion. So it's fundamental to have a good preparation, endoscopic preparation, and observe small changes in the relief, coloring, and to have a well schematized test. If you have BLI, and these brings an LCI, bring important information, especially if we can magnify. This type of equipment is very expensive, and even in Japan, they are not available for every endoscopic exam. So there are few equipment, but it's very important that we have this type of knowledge, because when we have our conventional this device, even with no magnification, in most cases, we are able to have a good detection capability and to determine if we're talking about a neoplastic lesion or not. So what's fundamental, it's been mentioned already, is the identification of the suspicious area with a white light. This is fundamental stage, and if we get this with conventional chromoscopy, with white and well-detailed observation, we'll get to a good diagnostic. And obviously, we're going to do the biopsy. But if we do not suspect, this patient will have problems with the diagnostic. We have identified this with, if we have DL, we observe the suspicious area. If there is glandular or vascular irregularity, we are talking about a neoplastic lesion. So these are fundamentals which are extremely important to have this knowledge, like defined by Professor Kenshi Yao. So to have these fundamentals, it's important. You see this case, it's very important to identify that there is an alteration in this region. So it's abnormal if compared to no normal one. This fold here that is thicker. This is what should call your attention. If this has called your attention, then we can do with indigo carmine or with other resource. Here we have used a BLI. Without magnification, you already can see that this is the normal standard, and when we get here in this region, you have an interruption. And here with magnification, it's more evident the alteration that you have in this depressed area. I call the attention that even if it's a small lesion, here you have a clamp, so this should be 5-6 millimeters, is a small one. It shows irregularity, and it grows issuing some prolongations. At the time of resection, we should do this broadly, because if we only do with this evident area, we'll have compromised margins. Mustactomy, for this type, EMR, even for small lesions, you have the frequency of a compromised margin. With white light, it's extremely difficult to identify suspicious area, but this is a training. So you see that in this region, with white light, it called our attention, but LCI accentuates this, the contrast of colors. So this makes it easier for us to identify the lesion, but not characterization. These new technologies, the papers show that will facilitate the detection of this type of lesion. So once we have identified the suspicious area, then we go to characterization, which is better with BLI. So this case, and I'd like to call your attention to this, that the lesion itself is in the superior area, but you see that in this region here we have a vascular alteration, which is only possible to be identified with this resource. If it's white light, and conventionally it's not possible to identify this type of prolongation of extension of lesion. So usually cancer, it stands beyond what we see in white light. So if we cut here, probably the margin will be compromised and patient will evolve with recurrence locally. So many cases of cancers show this type of pattern of growth that I call the attention to. This, when we use magnification, it's very evident. So in our routine, high technology equipment is not part of our daily life. Usually we have equipment like this. It's important to have a good preparation and to observe some erosions, but it's important to observe these erosions. If any calls our attention, then you see here particularity with a DL, and even without magnification with indigo carmine, we can see a very clear difference of this suspicious part from the peripheral area. So a biopsy is going to confirm that is adenocarcinoma. So even if we do not have all of the technology available every day in our routine work, the knowledge regarding magnification concept is extremely important. This is our daily routine. As I said in the beginning of the presentation, this lesion is a little different from the other ones. And in a detailed observation, the thighs, for example, that is a case done 5 years ago, we see an elevated area and a depression. With indigo carmine, it became more evident. So you have a light elevation with a depression that is apically presented. Now going to therapy. In this case, we have opted for mucosaectomy that is conventional. You see the lesion here, almost the angle incisure. The lesion is more evident. We have an elevation here with a depression. So we have delimitation. Injection into the mucosa. It's a procedure that is fast. Apprehension with this snare. In the moment of apprehension, you do a slight aspiration, but mucosaectomy of the stomach is much harder than the colon because the colon is thicker. So you have the result. Final aspect, new bleeding. But you see that despite this snare, the position that I found suitable, you see the resection was on top of the lesion. So the lesion left, but the mucosaectomy, from the technical point of view, it's not easy. Even if it evaporates less, its bleed is less, but for resection, a mucosaectomy that is perfect with a centralized lesion, it's something that is very hard. And this has been shown by the Japanese, and this is the National Cancer Center, which is a reference center for the endoscopic treatment. You see that even at this service that is highly qualified, you see free margins in strip biopsy up to 20 millimeters. Only 45% of this lesion had free margins. So 55 had compromised margins. So it's not a technique that is easy and and as a consequence, this is a Japanese study, but for a long time we had known that conventional mucosaectomy has a elevated rate of local recurrence, getting to 35%. So in such a way that this is an example of a patient where I had a diagnosis in 2015, an elevated lesion, posterior wall of the antrum, the diagnosis, and the patient disappeared. And last year the patient came back. So I said, I never forgot this case, so it called my attention. But the patient came back, and he had done a mucosaectomy. I don't know at which service, but he came back. And I examined the scar, and you see that there is a suspicious area, more irregular one with magnification. You see that there is a DL line with a glandular irregular standard, and the biopsy has confirmed a recurrence, a local recurrence, showing that mucosaectomy that was done in that case effectively was not fully curative. So in Japan at that time, mucosa, the classical indication for the treatment of early gastric treatment, you see here the local recurrence rate that is very high. Lesions such as this one, slightly elevated intramucosa, were treated with gastrectomy. And Professor Toda did the classical work published in the year 2000, evaluating these pieces. for early gastric cancer, according to the result of this study of this, in terms of the lymphnodal involvement, here's the indication of classic treatment. Here the expanded mucosal lesion, differentiated carcinoma without scarring, independent from the size, with scarring up to 3 centimeters, with SM1, the submucosal invasion up to 3 centimeters, and undifferentiated lesion up to 2 centimeters. This was the proposal of the expanded criteria that was defended by professor from the National Cancer Center, with the advent of the submucosa dissection, which allows us for the resection in block, even if we have unfavorable situation with pyloric channel, with fibrosis, allowing for histopathological examination, and with rates which are superior rates of curative resection if compared to the previous methods of mucosectomy. This is an example of a slightly elevated 2A, almost 10 centimeters, and curative resection. This was only possible with the advent of, the arrival of submucosal dissection. Now we are benefited by submucosal resection, which allows us, as in this case, a patient that came back with recurrence, local recurrence, and it was possible for us to reapproach this endoscopically. So these are lesions with scarring and fibrosis, which makes it difficult for resection. But this is a proposal for treatment for this type of lesion. So with the advent of the submucosal dissection and the endoscopic treatment, these are the National Cancer Center. With the advent of submucosal dissection, there is an exponential growth of endoscopic treatment with growth mucosectomy. Even in Japan, now it's done in very few cases. And recently, we had a conference with Professor Toyonaga. He said that 5 millimeters would be the limit. This according to the personal experience he has. Mucosectomy for gastric cancer for very, very small lesions. Practically, we do not do resection of mucosectomy in gastric cancer. This was shown by classical papers of Professor Oda of National Cancer Center, showing that ESD is superior in terms of resection rates. As a result, more curative resections. And still today, it makes it a little bit more complicated, the perforation, but today, with the improvement of techniques of devices and knives, the complication rates have been reduced. So knowingly, submucosal dissection has gained space not only in Japan, as in the Western world and in our country. With a better management of complication, bleeding, perforation, that in this case, which are complications that are solved immediately. ESD is much superior in resection at many levels. This is unfavorable. Obviously, lesions treated are bigger and the higher rates of complication and perforation. The inconvenience, there is a learning curve that is longer and with a higher cost. But the proposal for treatment are very different. So we are comparing procedures with different proposals. So here, regarding equipment, we have to do this. We need equipment, and this is very important to have the right angle well maintained. The jet, it's very interesting. If we have bleeding, especially equipment with high definition equipment with magnification, this is very important in some cases. A electrosurgical unit, water jet, caps, devices, knives, and coagulation clamps, injection solutions. We also have mannitol, Voluten, and other solutions getting to the market. But in our opinion, the hyaluronic acid would be the best solution that I consider as the best solution for the procedure. The CO2 insufflator, this is a resource that is very important. Recently, we have the guidelines of the Japanese school. We have absolute indication for the mucosaectomy and ESD, EMR and ESD, lesions up to 2 centimeters for differentiated types, and bigger lesions would be submucosal as undifferentiated type and with scars present. This is the indication for submucosal dissection. But even for small lesions, the technique that is recommended by Japanese is submucosal dissection, as European Society also recommends strongly the submucosal dissection. Even with lesion of 10-15 millimeters, the European Society elegantly recommends the submucosal dissection, even as a way to develop our technique, because we cannot start a submucosal dissection in a complex technique in a harder case. We have to start by a case, a more favorable position, a lesion that is smaller, as a learning curve. A place that I especially respect very much and I use hybrid is the high curvature of the fundus, because for submucosal dissection it's very hard to have good positioning, and we don't have the right insufflation. We have a cumulus of secretion, so it's this region is extremely difficult, and the National Cancer City had already published the high rate of perforation. So this type of region, the hybrid technique would be a good option of EMR or a combined technique, because in terms of positioning, the EMR in this region is not going to be very hard. But you have to be very careful, because even in mucosaectomy, you have the risk of perforation. So this region here, for example, it's a region that I especially do not like to do submucosal dissection. You see the accumulus of accumulation of liquid. We opt for incision, partial incision, and we complemented with this polypectomy snare. It's an interesting case. In the beginning, the lesion was not, it was recent, but we observed the lesion, chromoscopy, and it showed its face, and it was evident that we're dealing with a neoplasia, depressed with an elevated margin. The lesion here, it's very difficult. It bleeds, and EMR has its place in this type of location. About to close, this type of lesion is one that is restricted to this area, and it's very important to pay attention if we don't have the resource of magnification, and we see that there is an alteration in color. And here we have chromoscopy, and you see that we have an alteration of the glandular pattern, a lesion that is flat, a depression that is very shallow, and in the submucosal dissection, if we don't have equipment with magnification, it's important to have good observation. And if it's EMR, we would have removed just this region. With submucosal dissection, we could have a more broad dissection, and we have shown a neoplasia that is flat of 2B. So I call the attention to the type of demarcation. To have a well-detailed exam. This is another area, in an area of accentuated atrophy, the antrum going to cardiac. So it's important to do some training. Know that at some place there must be a neoplasia and there is a suspicious area. And the LCI has helped. And how do we use the LCI to identify the lesion? It shows to be a little orangish. If you have LCI with this orange color, so there is a great probability of dealing with neoplasia. So after the lesion has been characterized, you see a regular area and DL and an irregular area. The same thing here, non-neoplastic, altered DL and neoplasia. You see that this grows irregularly. In some cases, we did aleatory randomized biopsy, and you see an adenocarcinoma in this patient that has been referred to find the place of neoplasia, and you see that here there is DL and alteration of vascular pattern. You cannot see glandular. Elderly patient, different comorbidities. We opted endoscopic dissection, undifferentiated neoplasia, but there was no possibility to do surgical treatment. It was in 2018. Patient is being controlled and follows well. 3 minutes to close. Thank you, Professor. Now, we should not miss the opportunity for a diagnosis. And this patient is a patient. It's a problem in hepatology. And with indigo carmine, you show irregularity of surface, but we have not defined that it's a neoplasia. Here in 7 months, there was other events, other comorbidities. In 7 months, the lesion was very evident with an evolution that is very significant, that concerned me very much. And this is not following the sequence. He came for the control of varices. It's a discrete alteration of coloring. And this evident area shows the possibility to offer endoscopic treatment, vessels that are very thick, and the submucosa. This was in 2014. Recently, patients returned. There is no residual lesion. He is better and his liver problems. And the message I should leave is never miss the opportunity to make a diagnosis and offer endoscopic treatment, which preserves the quality of life. Rate of mortality in therapy is almost zero, different from the surgical approach. Thank you very much for your attention, Professor. Thank you. Excellent lesson. Now I yield the floor to Professor Vito. Good evening, everyone. I thank you all, and especially the group from Itaigara Memorial, for once again having invited us to be present here at the second seminar. I thank also the scientific committee of the Itaigara Memorial, and it's very good to be part of this group with you. All of the presenters and all of the people and the spectators who are here listening are thanking for your time. Thank Dr. Luiz Maruta. Remind Dr. Masegawa together. In 2019, we had a great course in Hospital Santa Cruz. Always great lesson. Thank you, Dr. Nelson, for always teaching us. And when we have doubts, we always get in contact with you. And it's always so pleasant and so kind when you respond to us. So we are going to yield the floor to Dr. Carlos Robles for his questions and to the lectures. Good evening, Professor Robles. I believe that it was just spectacular, the presentations that we had from Maruta and Professor Miguel. A presentation, excellent presentations with great didactic method, great images for our learnings of those who are part of the, for those who are part of this event. Dr. Dima showed the controversies regarding the mucosal dissection and lesions that are smaller than 5 millimeters. But he has also advised for a combined technique, and I'd like to know why. Should we use a combined technique? And really, the application of endoscopy regarding being able to get a higher number of people. How can we systematize this endoscopic derivation to be able to have the possibility to have better studies regarding the search for gastric cancer? So now to answer about treatment. Good evening, Dr. Carlos. Yes, the preference always is to have a resection, a complete resection with free margins, with curative objectives. And obviously, we don't want complications, of course not. And there are some indications according to the Japanese guidelines, there are some relative indications. With surgical treatment, there is high risk, even if it's outside the criteria, absolute criteria. If we compare to endoscopic treatment to be resected in monoblock, and that the piece is examined and you decide for an approach. In this case is here, and the endoscopic dissection would be the proposal. We have to evaluate risk and benefits of treatment for the patient because lesion could be the same, but depending on the operator, depending on the patient, depending on the structure that we have, even the surgeon. If the surgeon has a complication rate that is very high, maybe it's better to do it endoscopically. For lesions that we are going to do it with the dissection, submucosal dissection, in some situations we feel that if we continue, if we insist in submucosal dissection, we'll have some complication, perforation, and the result will be worse than if we insist. So it's important the operator to understand, to say that this case is going to be complicated. It's better for the patient to have the combined technique. I think it depends on each case, but always thinking about the result to benefit patients. So I don't think we should be concerned about statistics. Maybe statistically might be bad, but for the patient, I'm sure that it's going to bring benefits to the patient and no harm. And regarding the offer of a democratized screening, I think we should stratify patients according to many criteria. We have Olga, Mujin, or the Japanese criteria, and screen patients and do the right follow-up. But it depends on each country. Ecuador has a rate that is higher than ours. So I don't know if Brazil, it could be justified to have a campaign for gastric cancer, like in Japan, in Korea, in Chile, Costa Rica. Peru is very high. But I think in Brazil, gastric cancer, the perfect thing would be to have family history and stratify patients. Thank you very much for the question. Thank you. Nelson. Qual é a sua opinião sobre a diferença em relação ao Helicobacter? Agora, com os novos que nós temos, com os novos casos, qual é a sua opinião sobre a erradicação do H. pylori em pacientes com tratamento endoscópico com EDS? Can I answer? Yes. Effectively, the endoscopic control, if the resection was satisfactory, if it's according to the cure criteria, the concern are metachronic lesions. There is no, if it's the control should be done every 6 months, there is no study that would prove that one is superior to the other one. But what I recommend to my patients is when I see that stomach that is clearly sick with a lot of intestinal metaplasia that is difficult to evaluate, there must be some neoplasia somewhere. But it's below our capability of detection. It's an individual situation, depends on the operator, and depends on the equipment. But if I'm somewhere where my equipment LCI doesn't have LCI magnification, I would have an early endoscopic control. Regarding H. pylori, we recommend to do treatment. Of course, treatment does not confirm that there is not going to be cancer because the cascade has started. It's a sick stomach, but effectively we treat, but this patient needs endoscopic follow-up routinely, and there will be other lesions. And if the control is not suitable, I'll see that there is a growth, speed of growth that is much higher. So a patient that should be followed rigorously with a well-detailed exam. Could I ask a question? With H. pylori infection, I use the degree of atrophy, because when it's open, or 1 or 2 or 3, even if you treat the Helicobacter pylori, there is a risk of developing neoplasia. In the case of the atrophy, is less important. Many times we see the regression of the atrophy after the treatment of H. pylori. So I use the evaluation of the degree of atrophy after the H. pylori treatment. If it persists, then we should have the annual exam for patients. If there is no open degree of atrophy, I think we can relax, and the possibility of developing cancer is much lower. E a metaplasia intestinal nesses pacientes, para vocês é mais importante a atrofia ou o que você considera como sendo necessário para que ele sobreviva, o seu paciente? Eu considero a metaplasia intestinal associated to cancer and atrophy. So these are parallel things. I do not believe that intestinal metaplasia should be a necessary step for cancer. It is besides cancer. So it's a stomach with a high possibility of developing cancer. And so it doesn't matter if it's intestinal metaplasia, atrophy, if it's an advanced degree, so we should have a closer surveillance. Excellent. Dr. Nelson has talked about a clear example. Gastric lesions develop faster than what we see in other areas in gastrointestinal tract, so we have to be very attentive to high degree dysplasia. These lesions, when we see, despite of international guidelines saying that above 2 centimeters could be treated with EMR, we see that most of the times, as Dr. Nelson has shown, these areas when we treat oncologic areas, we have to treat the oncologic margin. So this limit of 20 millimeters is important. It's we see ever more lesions with margins, and we use ESD despite of having the anterior margin compromise. It doesn't make us comfortable because of fibrosis, but it's interesting not to have a gastrectomy. Now I yield the floor to Marcos and Daniel Lira with the questions from chat, and the reviews are great for Dr. Nelson, Dr. Maurita. Thank you very much for your presentations and lectures. Good evening, everyone. First of all, I'd like to thank the Itaigara Memorial Board, Dr. Rodrigo, Dr. Gilmar, Dr. Maruta, and Dr. Miyashima have made excellent presentation, not only in didactic terms, but especially for the image quality. What I see is that there is a need for a preparation of stomach for you to be able to visualize the structure, the morphology, the vessels morphology, and DL. So this is extremely important. And for that, we have to have a stomach that is well prepared. There are some points of intersection in both presentations, so my questions could be answered by both. So I'd like to know the preparation other than water. Do you have anything else that you would recommend? Nelson has already talked about the substance that he used in submucosa, but I also would like to know from Professor Maruta. And the decision of mucosectomy, EMR or ESD depends on the study of the surface. I see that not always the size will be a decision point. For example, 10 on 5 millimeters. What Vitor has said is extremely important. If the surface shows that there is a meaningful invasion in terms of depth, it could small, but then you go to ESD. I'd like to know about this. From the practical point of view, do you do prophylaxis with antibiotic in SD, EDS in the stomach? Nelson, can I start? I share the screen. I don't know if you can see it. Yes, you can continue. This is a preparation we standardized. Hasegawa, Dr. Hasegawa has published at an USP journal. We use papaina. It's an enzyme that used to... This is the solution that is on the slide. 1 gram of papaina, sodium bicarbonate, and simethicone. Water should be warm to absorb the substances. We give 15 to 30 minutes before the exam. It's a substitute for chelating, which we don't have in Brazil, but there is in Japan, and we have good results. So the mucus breaks down, and when we do the washing, the mucus leaves completely. It's an experience where we had a good result. So if you wish to use it, you could reproduce the results. Professor Nelson. In practical terms, every day, I use usual preparation, Luftal and water. And I offer a high volume glass before the exam. And I use the rest during the endoscopic exam, but I don't use acetylcysteine would be an option. But in our routine, I use Luftal, the usual preparation, but during the exam I use a lot of water with the syringe. If there is a pump, this would facilitate our work. But all of the case I have presented, it's water and Luftal. But if we can use any mucolytic, acetylcysteine, as Dr. Maruta recommended, it would be very interesting. Regarding injection, internet stopped, but Marcos, we use Voluven. Voluven can be used immediately. And the second option, mannitol. Regarding antibiotic therapy for stomach, I use Kefrazole. This is my routine. Thank you for your question. Congratulations on the course. Thank you. Maruta, do you use antibiotics? No, I don't. No, I don't. Good evening. A question for both. In the diagnosis of the atrophy or metaplasia, when we use the ALGA system, what's your guidance regarding the biopsy? Thank you for your question. We have discussed this a lot. I use the endoscopic parameter for the diagnosis of intestinal metaplasia and the atrophy. So if I can, I do not use the UGI. I do the endoscopic diagnosis. For clinical research, I think it's important we should understand where to do the biopsy of the gastric corpus. In the gastric corpus, either you're going to do H. pylori research and you're going to leave atrophy cases. If you fixate this place, the biopsy for H. pylori should be separate. The standard is 3 centimeters of the gastric corpus above incisor angularis and besides the small curvature, 3 centimeters from the posterior and the anterior. As Dr. Luiz Maruta said, reference patients. I do the same as Dr. Maruta. Good evening, everyone. Thank Dr. Rodrigo Felipe and the organizing committee. A well-consolidated event, and I thank Dr. Luiz Maruta, Dr. Nelson Miyajima, for having accepted the invitations with wonderful lessons that have been presented. Great the endoscopy evolution of equipment, but changing a Volkswagen to a Ferrari is very difficult. Now, putting together all the questions here to summarize, when is the biopsy not necessary? And when the biopsy done? How should it be done? Where in the lesion? To improve the diagnostic result and not also to take away the possibility of endoscopic dissection. The technology, I showed why I like this technology. There is another exam, because my experience, I followed the Japanese school of learning how to diagnose gastric cancer with white light. But it's not simple. It's not so simple. We have to have good training or do many biopsies. So answering your questions about biopsy, this high technology equipment allows you to do guided biopsy, and you're able to do the diagnosis even without the biopsy. But since we are obliged by law to prove that it's a cancer or some alteration, we do a minimum biopsy on the place where it's going to cause less problems to the treatment, to endoscopic treatment in the future. So we are reducing the need of biopsy to the removal of fragments, minimum fragments, and smaller number as possible. I don't know if I answered the question. Yes, perfectly. And adding another question, is there a role for echo endoscopy in the definition regarding what kind of approach should be used? I think it's for you, this one. Congratulations for the course. Thank you for the invitation, Dr. Daniel. Regarding technology, no service, even in Japan, would have every equipment, last generation equipment with magnification, digital chromoscopy. There are very few, even at the centers. I think that it's in our area, it's not so easy to find, but what we need is high definition. These are cases where I have 4400 for Fuji, which is inferior to 4450, so a high definition device. Most of the cases, we have to be careful. And it defines the nature of lesion. And in this moment, do the guided biopsy. Where do I do the biopsy? Where I think it's going to be positive. Usually, I do a fragment in the place that should represent the lesion. And thinking about the endoscopic dissection, if I can have a biopsy that is strategically is not going to interfere in my reception, I do in that place where it's going to interfere less. Vito does resection. There is some place where it's difficult because of the wall positioning and a series of momentaneous situations. So we are not going to do biopsy in that place if it's not necessary. So we'll anticipate that we'll have difficulties there. So we're not going to do it there. It was a pertinent, relevant, in a very representative place, and possibly that is not going to interfere in the procedure. But I always do biopsy, unless the patient has a contraindication for biopsy. Regarding criteria of endoscopic resection, without scars, dependent from size, if with scars up to 3 centimeters, if submucosal 2, undifferentiated to 2 centimeters. As Dr. Luis Maruta has shown, the limit of the lesion is very hard to be determined precisely. In most cases, you have this biopsy in the quadrants. I had lesions where I had diagnostic. When I went there for endoscopic resection, I did not even find the lesion. I did not find the exam that I did. I had pictures. I used to look at the pictures during the exam, and I didn't find the lesion. I did not have magnification equipment. I did not find it. And the patient had told me, I want one procedure, endoscopic or surgery, either one or the other one. I don't want to do endoscopy, and then if it's not curative, I go to surgery. I just want one. So I sent her to surgery. So undifferentiated lesion, even surgeons from Japan are also concerned about this. The margin very difficult. It grows below. You have an alteration in color. If you don't get to in the right place, you have a compromised margin. I had a case of a patient which had an undifferentiated lesion. Then after 5-6 years, the patient had a local recurrence. We approached surgically, and the patient is well now. It's been 4 years. But undifferentiated lesion should be respected because the differentiated one is much more common in young patients, and the objective is to cure the patient. If we can offer the endoscopic treatment, but the thought is to cure and treat patient in a definite way. So we should not lose this from sight. This should be our guideline, cure of patient. Thank you very much. Now, a very fast question for Dr. Luis Maruta. I'm asking how this histologic mapping of biopsies and control of these lesions, and to Dr. Nelson, the ESD, what he does usually. What I do is, in stomachs that are completely atrophic, we have to do the annual exam, and we have to use the device with advanced technology. After the usual exam, what I do is I use a small or middle magnification of image, and all of the areas are evaluated that could present cancer. If the place is altered, I'm going to stay longer, but I do general evaluation from the endoscopic point of view. I do biopsies guided. When there is a suspicious place, I do a biopsy in that place. I don't do random biopsy or standardized biopsy. Okay, Dr. Nelson, ESD, most usual technique. Question, can you repeat it? If you can, the technique that you use the most, very fast, the ESD technique. There is many people asking how you do this and how you could explain this. EDS. Submucosal dissection, EDS, is a technique where we do the markings. At some time we have to have magnification, digital colonoscopy. We limit it 5 millimeters outside the lesion. We do the injection of a solution, Voluden or mannitol, so we can have an elevation of the submucosa so that we could have an area that with the perforation we inject, and I do a partial incision. I do a partial injection, partial excision, and I start the submucosal dissection. After part of EDS being done, I complement the incision and I finalize EDS. At that time, you identify vessels, hemostasia. This is EDS. To close this lesson, I'd like to invite Professor Robles for his final considerations on this lesson. Professor Robles. Thank you. I congratulate the committee, the organizing committee. I think it's very important what has been said regarding the experience. Professor Maruta's diagnosis and Nelson, who's a prominent techniques, and so thank you very much for having invited me to participate in this event. Thank you. Now we'll start the second lesson with Professor Naoshi Yoshida, professor from the University of the Kyoto City Hall. I had the opportunity to be with him for some time. He's a well-experienced man who's going to bring a lot of knowledge to us. And associated to this knowledge, we'll have the moderator, Dr. Vitor Nunes Arantes, myself, who's coordinator of Ssld and Alpha Institute, and Professor Lix, professor of endoscopy and colonoscopy from PUC Campinas. Professor Yoshida, good evening for us. Hello, can you hear me?
Nice to meet you, everyone.
Muito bom encontrá-los. Meu nome é Yoshida, sou do Japão, de Kyoto. Inicialmente, eu gostaria de agradecer por me convidarem para esse fantástico seminário brasileiro. Eu estou tão
Today I have two presentations about endoscopic diagnosis for colorectal tumors and endoscopic treatment, especially about ESD. So let me show you my presentation. Can you see my presentation, everyone? It's okay?
Yes, Sensei, it's okay.
Okay, thank you, Vitor.
Muito bem. Muito obrigado, Vitor. Então, inicialmente, gostaria de falar sobre a endoscopia avançada para o diagnóstico diferencial do neoplasmas coloretal. Inicialmente, então, vocês lembram de mim aqui como um endoscopista que também é uma pessoa que gosta muito de corridas. E deixe-me mostrar aqui para vocês também sobre Kyoto, que é a minha cidade natal. Kyoto está aqui, que é uma capital antiga do Japão. E também está localizada a 500 quilômetros a oeste de Tóquio. Então você pode vir a Kyoto de Tóquio utilizando um trem fantástico como esse, mais ou menos me mostrar alguns deles para vocês, algumas fotos desses templos. Aqui é
this is Shimogama Shrine. It is a World Heritage. And yeah, in autumn, please go to Arashiyama. You can see fallen leaves. And this is Kiyomizu-dera Temple. It is famous about cherry blossoms. And when you come to Kyoto Station, please check Kyoto Tower like that. And your friend, Dr. and Dr. Felipe, fortunately came to our unit in 2018. And yeah, of course, they enjoyed Kyoto very much. And another, my friend, Dr. Arantes, also came to Japan with his family and his friends. And yeah, please come to Kyoto someday. Anyway, so today's topic is first, tumor characterization, and second, tumor detection. So let me ask one question. How do you treat this polyp? A polyp, yeah, very small, 8 millimeter on the rectum. So one is no treatment. Second, cold snare polypectomy. And third, EMR. But before deciding therapeutic methods, please do BLI magnification like this. As you can see it clearly, left side is regular. However, the right side is irregular. So the answer is EMR. Don't do cold smear polypectomy for this kind of pre-malignant polyp. So the important thing is tumor characterization before treatment. So let me explain about BLI and LCI with laser endoscope, as you can use it in Brazil. Laser endoscope was released in 2012. Two lasers and phosphor illuminated the GI tract like this. And you can do BLI and LCI with laser endoscope. And they enable us to polyp detection and polyp characterization more than white light imaging. And using BLI magnification, as you could see in the previous slide, yeah, you can see surface pattern and vessel pattern very clearly. Let me show you a movie about laser endoscope. It is superficial lesion 40 millimeter in size on the sigmoid column. However, in this Zoom meeting, the quality of image is a little bit worse than a regular presentation. So I'm sorry about that. Please forgive me. So let me show you a video. So BLI and LCI makes the lesion clearly, especially in LCI, lesions becomes reddish. And in BLI, as you can see, lesions becomes brownish. And this laser endoscope enable to magnify a lesion 135 times. And surface pattern and vessel patterns are detected very clearly. So as you can see, there are no destructive pattern on the surface. So we diagnosed it as high-grade dysplasia, and we did ESD for this lesion. And let me explain about another new style endoscope, Elixir. As you know, it is an endoscope using LED. And it was released in 2016 to 2017 for some areas in which laser endoscope have not been approved for use, especially in the United States and Europe. And in Brazil, you can use this. And this system enables the performance of blue light imaging, not blue laser imaging. However, this is also called as BLI and LCI, using multi-light technology of LED lights. This is a comparison difference between laser and LED endoscope. However, in LED endoscope, as you can see, narrow band light such as blue-violet LED and blue LED enable us to detect the surface pattern and vessel pattern very clearly. And this is a comparison between LED and laser. As you can see, in LED endoscope, the images of white light image is a little brighter than laser endoscope. And regarding LCI and BLI, yeah, these images are almost similar. Now we are performing a multinational study for proving this non-inferiority. So in the future, we will report the evidence about this. And another topic is this, EVIS X1. This new system was released from Olympus worldwide on July 3rd, 2020. As you may know, Yeah, there are several new functions such as TXI and RDI and new style NBI. And then this is images of TXI. Using TXI, you can detect lesion more easier than white light imaging. And NBI is also improved. The image is more clear than previous model. And this system uses 5 colors LED like this. So let me explain about the difference between NBI and BLI. As you can see, NBI and BLI, the images are almost similar. However, there are little a small difference between two images. The color is different due to each setting. And the more important is that the surface and the vessel pattern are enhanced, more enhanced in BLI like that. So it is a good things, and it is sometimes a bad things. So please think this enhancement in BLI. So I explained the difference between NBI and BLI in a previous slide. So how can we use nice classification for BLI? Because nice classification is originally made for NBI. And how about this? This is our Japanese NBI magnified classification called as JNet classification. Yeah, it is initially originally for NBI magnification. So BLI magnification may not be suitable for this NBI magnification. However, previously, we performed a study about BLI magnification using NBI classification. So as you can see, accuracy rate is almost similar between BLI and NBI. And the consistency rate of BLI and NBI for same tumor using NBI classification is 81.7%. It is, we thought it is very high. So we concluded, according to this result, we could use various NB classification for BLI magnification. So please use NBI classification for BLI magnification. This is a nice classification with BLI. This is type 1, type 2, and type 3. Almost similar to NBI. And this is JNet classification with BLI. So we can use JNet classification for BLI magnification. And type 1 is hyperplastic polyp. Type 2 indicates adenoma. We called it as regular pattern. And type 2B is a regular pattern. It indicates high-grade dysplasia. And type C is destroyed pattern. Yeah, it indicates T1 cancer. So please do surgical operation for these kinds of tumors. So you can decide therapeutic methods using this BLI magnification of JNet classification. So may I ask one more question? What is JNet classification for this lesion? Yeah, this is a polyp, 7 millimeter in size on the sigmoid column. It is not so big. So someone may do cold snare polypectomy for this lesion. But using BLI magnification or BLI non-magnification, how do you diagnose this tumor? For NBI and for JNET classification, type 1, type 2A, type 2B, type 3. So the answer is type 3. So it is an indication for surgical operation. Yeah, histology showed T1 cancer. However, she was very old, so we performed ESD for this lesion. So there are various kinds of classifications in the world. And this is a report from Dr. Carlos dos Santos and me. Yeah, this is a report about the BLI classification of Teixeira classification made by Dr. Teixeira. Yeah, it showed a good result for accuracy for diagnosing colorectal tumors. So please use Teixeira classification in Brazil. And how do you diagnose this kind of tumor? Yeah, BLI shows a tumor clearly, and BLI magnification shows like that. Yeah, it is SSL. Yeah, as you know, SSL now recognized as precursor lesions for CRC. So in clinical practice, we resect SSLs similar to adenoma. And about 8% of all detected polyps are SSLs. So we have to diagnose SSL clearly compared to hyperplastic polyp. And unfortunately, JNET classification and NICE classification is not useful for diagnosing SSL. So we recommend these two endoscopic findings of NBI and BLI for diagnosing SSL. First is ECO, expanded crypt opening, red circle. So you can see blackish dot. And second is thick branched vessels like that. Yeah, a vessel, thicker than regular vessel. And if a lesion with either ECO or TBV, a sensitivity of those lesions 97%. So please resect a lesion with either ECO or TBV according to size of tumors. And regarding SSL, we have to care about SSL with dysplasia, SSLD. SSLD is a precancer lesion, so we have to not to perform cold snare pulpectomy, but to do EMR or ESD for these kinds of lesions. And endoscopic findings for diagnosing SSLD is a report showed nodular or protrusion in the surface of lesions are very important findings for diagnosing SSLD. And another important thing is tumor size. Less than 5 millimeter and 5 millimeter, there are no SSLD. And more than 6 millimeter, yeah, there is a possibility of SSLD. And the rate is increasing according to the size of tumors. So please use nodule and tumor size for diagnosing SSLD. And regarding BLI finding for SSLD, we recommend irregular vessel on the surface. The left image is a white light image of SSLD, and as you can see, there is a slight reddish area on the surface. Red square. And the blue square is not so reddish. And the blue square's magnification is like that. Yeah, it shows ECO, crypt opening. And in red area, you can see irregular vessel like that. And we did ESD for this lesion, and as you can see, red area, reddish area showed high-grade dysplasia. So, yeah, I'm a runner. So I sometimes run overseas. Yeah, sometimes with your Brazilian friends like that. And yeah, next topic is polyp detection. So as you may know, BLI improves polyp visibility very more than white light image like that. You can find polyp easier than white light imaging about adenoma and about SSL. And previously, we reported a randomized control study for proving BLI's superiority than white light imaging about polyp detection. We examined total colorectum in this study. And this is the main result of this study. As you can see, number of polyps per patient in BLI group is significantly more than those of white light group. So BLI is very useful for polyp detection. However, we also found a demerit, not a good thing about BLI. BLI's observation time was significantly longer than white light imaging. We discussed this demerit among our researchers, and probably it was due to darkness of BLI. And another problem, maybe this is the biggest problem in BLI and NBI for polyp detection. Yeah, the residual liquid become reddish, and it makes the view dark. Generally, 25% of patients receive insufficient bowel preparation like that. So NBI and BLI is not so useful for these patients. However, for resolving these problems, liquid color imaging (LCI) is released from Fujifilm. Yeah, as you can see, it is brighter than BLI. And LCI makes polyps more reddish and makes normal mucosa more whitish. So polyp visibility is enhanced more than white light imaging. Additionally, residual liquid becomes yellowish like that. And there are lots of papers for showing LCI's superiority about polyp detection. Let me show you some examples, some papers. Yeah, first is our paper. Yeah, we originally made this classification, polyp's visibility. Polyp's visibility is endoscopist feeling for polyp detection. Score 4 is excellent visibility. You can find a polyp very clearly. And the score 1 is poor. You cannot find a polyp. And the score 3 and 2 is like that, intermediate. And using this score, yeah, let me show you an example. This is a white light images of small superficial high-grade dysplasia. Yeah, our visibility score is 2. Maybe some of audience can find a polyp. However, it is a little bit difficult. However, using LCI, you can find a polyp very clearly. Polyps becomes reddish. And this is high-grade dysplasia. And our score is 4, very good visibility. And using this scoring system, as you can see, LCI's score is significantly more than white light imaging. And regarding various factors, endoscopist skills and locations and size and histology, about all of them, LCI's score is more than white light imaging. So LCI improved polyp visibility significantly more than white light imaging. And let me explain about other studies showing LCI's superiority. This is a report from a European group. They examined only the right-sided colon, and this is a tandem style study. And they compared white light group to LCI group. And as you can see, adenoma miss rate in LCI was significantly less than white light imaging group. And another report is from Brazil. Dr. Carlos dos Santos reported it. Yeah, but it is very significant, interesting report. They compared white light imaging, BLI, and LCI. And adenoma dissection rate was examined. And as you can see clearly, ADR in LCI group was significantly more than white light imaging. So recently, we recommend LCI for routine colonoscope observation. And another study is like that. You can see various types of polyps, and yeah, LCI's polyp visibility is more. Yeah, you can find polyp easier in LCI than white light imaging. And we calculated color difference values in all of endoscopic figures. We examined 54 polyps, and as you can see, LCI's color difference values are significantly more than white light imaging. So not only subjectively, but also objectively, LCI's polyp visibility was proved. And I'd like to show a movie about LCI. And recently, we use LCI for second observation. First observation is performed using white light imaging for right-sided colon. And then we insert from hepatic flexure to cecum again. And only 30 seconds LCI's observation is performed for preventing polyp miss. I will show you a movie. Yeah, this is first observation using white light imaging, maybe 2 to 3 minutes. And then we reinsert to cecum from the hepatic flexure, yeah, only for right-sided colon. And LCI showed big lesion, superficial lesion like that. Yeah, this is an LSD having depression, and yeah, it was T1 cancer. However, we could dissect, we could find it LCI's second observation, and we could treat it with ESD. So yeah, I recommend LCI. And yeah, another endoscopic topic in our field is this AI. Yeah, LCI is good. However, AI is another improvement. And this report showed LCI's adenoma detection, CAD eyes adenoma detection rate is significantly more than only endoscopist. 14% more than only endoscopist. So we may recommend AI for polyp detection. And as you know, a CAD eye is released from Fujifilm, And this is useful for not only for polyp detection, but also polyp characterization. AI, when AI find a polyp, this annotation box is shown in monitor, and it is approved for white light imaging and LCI. And for polyp characterization, we change it to BLI. And BLI can diagnose each polyp. In this polyp, in BLI view, you can see neoplastic pattern. So we do maybe cold snare polypectomy for this lesion. And how about another small polyp? This polyp. This polyp is diagnosed as hyperplastic, so we do not have to dissect it. So it is very useful. And the accuracy of CAD-E and CAD-X are 95.7% and 83.6%. And this is my take-home message. Regarding LDA and laser endoscope, colorectal tumors are well diagnosed with BLI, so please use BLI. And polyp detection, I recommend LCI. Please use LCI if possible. And I'm a runner. When I run, I try to increase public awareness for colorectal cancer screening. So thank you. Thank you for your kind attention. This is my first presentation. May I continue second one? Okay, so I do next one. Aren't you tired? Not so much. Is it okay? Okay, so we start next presentation. Can you see my presentation? Is it okay? So next topic is endoscopic treatment for colorectal tumors. So how do you treat this kind of big tumor, 15 centimeter in size, and this is a circumferential lesion? Before deciding endoscopic treatment, we did BLI magnification like that, and it showed irregular pattern, but not destroyed pattern. So we diagnosed it as high-grade dysplasia, and we did ESD like that. And very big. And it is maybe larger than Brazilian steak. And let me explain about our experiences of colorectal ESD. We started ESD in 2006, and so far we performed 1,502 cases of colorectal ESD. The en bloc dissection rate is 95.3%, and the procedure time is 73.8 minutes. However, our skill is still improving. In recent 100 cases, our perforation rate is only 1%, and mean procedure time is 57.6 minutes. It is within 1 hour. So today, I will show you our tips for colorectal ESD. And yeah, as you know, there are risk factors for incomplete dissection in ESD. So we have to care about these things. First, tumor size, more than 50 millimeter. And second, severe fibrosis. And third, difficult manipulation. So let me introduce our tips for difficult lesions with large size, severe fibrosis, and poor operability. But I recommend don't do ESD of these, having these factors not in the beginning stage. Yeah, this is very challenging. So please do easier case in first beginning stage. And this is our endoscopic device for colorectal ESD. Yeah, initially, yeah, we used flash knife. Yeah, like that. It is a needle type knife. However, we changed it to clutch cutter mainly recently. And we also use special endoscopic cap and traction device called as SO clip. And injection liquid is also important. And another thing is clearance, lens cleaner. And unfortunately, it is not released in Brazil. However, it keeps endoscopic clean during ESD and during routine endoscope, such as EGD and colonoscopy. And according to these changes of devices and increase of our experiences, our ESD's therapeutic results is improving like that. En bloc dissection rate showed significantly better than in the beginning stage. And the perforation rate was, yeah, initially our perforation rate was 15%. Yeah, very high. So my boss became very angry about that. However, now our perforation rate is decreasing, and yeah, maybe my boss becomes happy. And there are various kinds of ESD knives. Yeah, each knife has each merit and each demerit. So please decide your favorite knife among these knives. And the flash knife BTS is one of my favorites. Flash knife is, as you can see, is a tip-shaped knife. And initially, it was a needle type knife, needle-like, like that, figure A. However, it was changed to ball tip knife, like that, in figure B. And we can scratch the tissue. Yeah, and hemostasis function becomes improved. And also, this knife effectively enables injection function. And 5 years ago, maybe, a flash knife was improved. It became longer for overseas, and it became thinner than previous one for improving vacuum function, like that. And another our favorite is clutch cutter. Now we use this knife mainly. Yeah, as you can see, it is a scissor type knife and can do incisions, dissections, and hemostasis. And it is safer, I think, compared to other needle type knives because there are no unintentional perforations. And it is especially useful for beginners, I think. However, clutch cutter is not approved in Brazil. I'm sorry. But yeah, there are another option, SB knife. Yeah, and SB knife and clutch cutter is almost similar. And in 2019, I wrote a review about how to use clutch cutter and SB knife for endoscopic ESD. So please read this if you like. And another thing, considerable thing, is for assistant. Rotating scissor type knife is a little bit challenging, so please practice it before use. And I'd like to show a movie about clutch cutter. Yeah, this is a anal canal lesion. And yeah, as you know, there are lots of vessels in this area. However, using a clutch cutter, we could dissect it yeah, safely. And this is anal canal part. And yeah, we now incise the surface mucosa. And you can see lots of vessels in the submucosa. However, a clutch cutter could dissect it without exchange of hemostatic forceps. If you use needle type knife for this kind of lesion, you have to exchange needle type knife to hemostatic forceps frequently. However, this knife, you don't have to exchange it. And this kind of big vessels are also dissected without hemostatic forceps and without bleeding. And yeah, mucosal incision is also can be performed with this knife. And this kind of palpable pulsation vessel can be also dissected with clutch cutter. However, sometimes bleeding, pulsation bleeding happens like that. However, clutch cutter could stop it immediately. You don't have to exchange it to hemostatic forceps. It is important merit about this device. And if you can find pulsation vessel before dissecting, you can do soft coagulation or such as pre-coagulation before dissection. And you can dissect these kinds of vessels without bleeding. So it is very useful. And my colleague, Dr. Osamu Dohi, previously reported about the efficacy of clutch cutter for upper GI ESD. He compared clutch cutter group to IT2 group. And regarding non-expert, as you can see, self-completion rate was significantly higher in clutch cutter group. And another good thing is intraoperative bleeding point. Bleeding number is significantly less in clutch cutter group than IT2. And finally, procedure time in clutch cutter group was significantly less in clutch cutter group compared to IT2. So for beginners, I recommend clutch cutter because it enables to control perioperative hemorrhage. And another report from my colleague, Dr. Ken Inoue, yeah, it is about colorectal ESD. Similar to upper GI ESD, the procedure time of training is significantly less in clutch cutter group than flash knife group. So I recommend upper and lower GI clutch cutter is recommended. And another important thing is injection solution. Yeah, don't do saline for colorectal ESD because its elevation disappears easily, as you can see in the EMR. Available solution is different in each country. In Japan, we use hyaluronic acid like that. In America, they use Eleview polymer. And in Australia, they use gelatin, called as gelfusin. And decent injection liquid is released from Boston Scientific. It is Orice. It is made of polysaccharide. However, in Brazil, there are a little bit problems about the injection solution. However, Dr. Arantes reported efficacy of off-label use of hyaluronic acid like that. So in gastric ESD, off-label hyaluronic acid, it is an eye drop. You may know it. It is very useful for ESD as an injection solution. So please use it. And another topic about ESD is this pocket creation method. Recently, lots of endoscopists, expert endoscopists use this method for all of ESDs. Yeah, this is almost similar to a poem. Yeah. And PCM enables us to perform speedy dissection. And it is originally developed by Dr. Yamamoto in Jichi Medical University. Yeah, it is a pocket. We make it below the tumor. And in a pocket, endoscopic view is like that. Yeah, it is very stable. So you can do accurate dissection. And there are 4 advantages of PC pocket creation method. So it prevents leakage of injection solution, and it has good traction by stretching the submucosal tissue. Yeah, so please try pocket creation method for next ESD. And we previously reported PCM's efficacy for lesions having severe fibrosis. Yeah, severe fibrosis is like that. Yeah, very challenging. However, using PCM, you can dissect this fibrotic area very accurately. And this is our main result. Procedure time of PCM is significantly less than non-PCM methods. And the en bloc resection rate is also significantly higher in pocket creation methods. So PCM is useful for severe fibrosis and also useful for dissecting large tumors. Let me show you an example. This is very challenging. Circumferential lesion on the rectum. The size is almost more than 10 centimeters. Yeah, BLI magnification showed irregular pattern, so it was diagnosed as high-grade dysplasia. And we made 2 pockets for this lesion, using clutch cutter and using a flash knife. Yeah, the upper left one is first pocket, and down lower right one is second pocket. And finally we could dissect it en bloc. And this is like a donut, but we could dissect it en bloc with 125 minutes. Another example for showing efficacy of pocket creation method is like that. This is a lesion, 30 millimeter in size on the ascending colon. And during ESD, we could find unusual thing in submucosa like that. Initially, I thought it was a big vessel or something, but I didn't have any idea about this. But I dissect. Here is muscle layer, and this is unusual structure. But we dissect it, and I diagnosed it as diverticulum. But using pocket creation method, having good traction, we could dissect it en bloc. Yeah, this is diverticulum. Yeah, very challenging case, but we could dissect it with ESD. And another famous and popular thing in Japan about ESD is traction method. Yeah, the SO clip is released 2 or 3 years ago. It is a clip having a small spring like that, and it can pull the lesion up, and you can see the cutting line clearly. And Dr. Sakamoto developed this device, and they reported this challenging case. This is SSL on the appendiceal orifice. Yeah, it is very challenging for endoscopic dissection. However, using this traction device, SO clip, the lesion is pulled up like that, and they could dissect it en bloc and without any complications like that. And their reports showed dramatical results about SO clip. The mean procedure time in SO clip is only 37.4 minutes. Yeah, like a EMR. Yeah. So SO clip enable us to decrease mean procedure time of ESD. Yeah, very significant device. In our recent 100 ESD cases, we also use this device, and the mean procedure time is 15 minutes. And let me show you our case. This is 35 millimeter on the rectum, and no severe fibrosis. And yeah, using SO clip, the lesion was pulled up, and we could dissect it very clearly and very speedy. So how do you think about procedure time? Yeah, very short. It is only 31 minutes. So SO clip, I think, is very useful. Let me show you a video about SO clip. This is a lesion, polypoid type, 50 millimeter on the ascending colon. And we use clutch cutter, and we use SO clip, and also we use pocket creation method, and this kind of tumor. And SO clip was deployed after full circumferential incision. Okay, yeah, this is SO clip, and it was deployed from the anal side of the tumor. Yeah, it was deployed, and then another regular clip is deployed and pull the ring up like that, and put it on the opposite side of colorectal wall. Yeah, it takes 2 to 3 minutes in our experiences, not so long, like that. And as you can see, submucosa could be seen very clearly, and speedy dissection was performed after that. So, but SO clip is not approved in Brazil, America, and Europe. I'm sorry. But there are another option about the traction method. A clip and line method. Maybe you use it in gastric ESD. However, for colorectal ESD, it is also useful. And you can make it by yourself using surgical suture. And another new device was released this month in Japan, a multi-loop. It is also a kind of traction device made of rubber. And this is through the scope type. And any endoscopic clips can be used for this traction device. And this is a little cheaper than previous traction device. And this is very soft rubber, so you can cut this rubber using biopsy forceps after dissection. And a report showed efficacy of traction method like that. Procedure time of traction method group showed significantly shorter procedure time than procedures without traction devices. So we recommend traction devices for colorectal and gastric ESD. And we change our theme to another endoscopic treatment. In Japan, maybe in Brazil, 3 endoscopic dissections are used for rectal polyps. First, cold snare polypectomy. Its indication is adenoma and SSL less than 10 millimeter. So don't do it for high-grade dysplasia. And EMR and precutting EMR is for any polyps. But this has a size limitation. I think it is good for lesion 11 to 30 millimeter, maybe. And ESD is, as you know, it has no size limitation. So we can dissect very large tumors using ESD. And let me show you improvement for EMR in couple of minutes. And regarding EMR, the problem sometimes happens like that. Poor elevation sometimes happens like that. And due to this poor elevation, multi-piecemeal EMR and long-time EMR is performed accidentally. And another problem is like that. This is a lesion, SSL, 30 millimeter in size. And it had good enough elevation. However, after resection, there was a perforation. So it was too big for regular EMR, I think. So let me introduce pre-cutting EMR, a very small tip for improving EMR's results. Pre-cutting EMR is a technique. It's a method before incising the circumferential pharynx of the lesions, full or partial. It depends on the lesion, and is named as pre-cutting EMR. Let me show you an example. This is a superficial lesion, 30 millimeter in size on the ascending colon. But it is, I think it was a little big for regular EMR. So we could incise full circumferential before dissection. After that, the tumor was shrinked, and the snaring was performed accurately. And we could dissect it en bloc. And the procedure time was significantly less than ESD, only 20 minutes. And cost is another important thing. In Japan, our endoscopic procedure fees are like that. EMR less than 20 millimeter is $500. EMR more than 20 millimeter is $700. ESD is, yeah, like that, very expensive. So we have to prevent ESD for decreasing our medical fee. So let me show you about pre-cutting EMR. Yeah, this is 12 millimeter in size, and it has depression on the surface. Yeah, using a snare tip, we could incise 1 centimeter to 2 centimeter before dissection. Yeah, sometimes for this kind of small polyp, we experienced not a good elevation. So for these lesions, we do pre-cutting EMR. Of course, we also do pre-cutting EMR for large lesions, 20 to 30 millimeter. And another thing is another lesion is like that, a very big lesion. And after injection, we do full circumferential incision like that. Yeah. Also, we used snare tip. And this is SSL lesions. So it is much easier than real ESD, and good for cost effectiveness. For injection, please use hyaluronic acid for this this technique. And after full circumferential incision, snaring seems very easy, not slipped, but you catch the tissue tightly, accurately, and you don't have to push the snare not too tight on the colorectal wall, so perforation don't happen in this technique. And it is our main result of pre-cutting EMR about the lesions more than 20 millimeter. As you can see, pre-cutting EMR group's en bloc dissection rate was significantly more than standard EMR. So we recommend EMR for medium-sized polyps, so 20 to 30 millimeter maybe. And for mastering ESD and high-quality EMR, it is very difficult. However, my recommendation is join hands-on seminar like that and watch experts' technique. And there are lots of hands-on seminar in the world. And our Brazilian friend also performed hands-on seminar and live seminar like that. And my friend, Dr. Miyajima, and me had a hands-on seminar in America previously. And DDW, perform schedule hands-on seminar every year. So please join this kind of hands-on seminar. And our JDDW is also have a hands-on seminar session. So please join hands-on seminar. And Dr. and Dr. Felipe came to our unit for watching my ESD. And yeah, endoscopic training model is recently brand new, improved. This is decent Japanese animal model. Yeah, it is animal model, but it is dissected model, not a live model. However, you can see vessels like that. And for EMR, yeah, you can do it using this model. And yeah, the left and right figure is almost similar to humans colorectum. Yeah, this has a fold, and the lesion is like a LST. So we can do this kind of training using this animal model. However, animal model is a little bit problematic for use because it is not so clean. So you cannot use it in your endoscopic unit. So it is very annoying. However, recently we use artificial training model like that, endogel. Endogel is artificial, not from animal model. So you can use it in your endoscopic unit. And yeah, you can practice this kind of traction method. And yeah, we did it in Australia last year, and 3 doctors dissected a lesion en bloc without any perforation. Yeah, they are very beginner, but they did it. And yeah, if you like this kind of training, please contact me, Facebook or email. I can help you. And this is my take-home message. Endoscopic treatments such as ESD and EMR are improving year by year. So please implement these techniques in Brazil. Thank you for your kind attention. And yeah, these are beautiful images of Kyoto. So please come to Kyoto someday. Thank you very much.
Muito obrigado, Rodrigo, pelo convite. Uma honra estar aqui. Sensei Yoshida, muito bom vê-lo saudável. Obrigado pela citação de 2 dos meus artigos. Foi uma honra tê-lo como coautor em um deles. Uma pergunta do ponto de vista prático, na nossa rotina diária, qual o impacto da imagem avançada no diagnóstico diferencial entre as lesões neoplásicas e não neoplásicas em relação à conduta endoscópica?
Yeah, thank you for special valuable question, Dr. Carlos dos Santos. And yeah, I couldn't hear your voice, so please translate it into English again. Please do it to translator or Dr. Carlos, both, either of them. Because your Portuguese and English is combined in my headphone.
Eu tô com problema no áudio aqui, só um pouquinho.
Oh, Oh, thank you very much.
Qual o impacto? Não, vou fazer uma pergunta mais curta.
Yeah. English is better.
Vou fazer uma pergunta curta. Qual o impacto da imagem avançada?
Imaging, yeah.
Na conduta endoscópica, para diferenciar lesões neoplásicas e não neoplásicas. O meu áudio está...
Translator, please repeat it. Carlos, I'm sorry, but your Portuguese and translator's English was simultaneously. So I ask a translator to translate Portuguese into English after Carlos saying, not simultaneously. Your headphone is out of order. Oh.
Ok. Primeiramente, muito obrigado pelo convite. E como nós estamos tendo um problema de transmissão, eu vou perguntar em inglês para ele poder entender. Pode ser? So, Sensei, so nice to see you.
Yeah,
and
nice
we
to see
are
you.
very pleased to visit you in Kyoto. And I would like to share with our friends here in Brazil that what amazed me most in Kyoto in Dr. Yoshida unit was not only his competence and his sympathy to receive us, but also his teamwork. So he has a group of colleagues and clinical engineers and young doctors that work in close collaboration. And they know each step of the procedure, what kind of approach and what kind of interventions they should do to help Professor Yoshida perform these wonderful procedures that we've seen in his presentation. I was very, very much impressed about the training of the people that worked with you. So my question for you is, could you share with us, how have you been training your colleagues, your clinical engineers, your junior doctors, in order to be a very good assistant for endoscopic intervention?
Yes, it's a good question. Thank you for Professor Beto. Yeah, as you know, we have lots of members in our unit. There are regularly 5 or more young doctors in our colorectal unit, and 5 another clinical technician for other assistants in our unit. And training for assistants and junior young doctors are very challenging. However, we do hands-on seminar in our single unit, in our unit every season, so every 3 months, including endoscopic technicians, not only for doctors, but for technicians and nurses. And clutch cutter is challenging for assistants, as you know. So rotating clutch cutter is skillful. So we also teach it to technicians in hands-on seminar, not only in clinical cases. So, but it takes only 3 months, more or less. After that, they can rotate clutch cutters, and they know ESD strategies and also ESD EMR strategies. And for junior doctors, yeah, I don't ask them to perform gastric ESD before colorectal ESD if they use clutch cutter. So after 10 cases of colorectal ESD, they can do a colorectal ESD by themselves. However, they need experts watching simultaneously. So don't do it by themselves. With my another colleagues expert watching, they can do ESD in 3 months. Thank you for your question.
Thank you, Sensei. Thank you very much.
Primeiro, eu queria agradecer o convite, Romano. Grande prazer. Dr. Yoshida, congrats for your great presentation, like always.
Thank you.
I visited Kyoto, I think 7 years ago, but unfortunately I did go to in your unit.
Yeah. I missed you.
In the future, I'll be there for sure.
Maybe.
Then I have 3 questions. First, what set you use in every unit when you're using a clutch cutter? Second, do you do and with lesion, do you think it's a good option to do underwater EMR?
Oh, yeah.
And last one, and when you did your dissection and finally you find a vertical margin more than 1,000 micrometers, only the bad criteria is this, not lymphatic or vascular invasion, well-differentiated adenocarcinoma, but only the criteria is deep vertical invasion. What do you think? What do we have to do with this patient?
Whether we have to do surgical operation or not?
Yes.
Yeah, okay. So first question is, I recommend Bio 3. Yeah, Bio 3 is 300 is also acceptable. However, Bio 3 has more power, and clutch cutter is a big device, and it needs more power. So Bio 3 enables us to perform speedy and beautiful incision. In Bio 300D, yeah, for especially about incision, the mucosa becomes a little bit whitish due to loss of power. So I recommend Bio 3 for clutch cutter. And second question is underwater EMR. Underwater EMR is, in my experience, I recommend it for lesions 10 to 20 millimeter with fibrosis, especially about recurrence of endoscopic dissection. For regular lesions, I do still conventional EMR, injection EMR. Yeah, I'm conservative. And I don't recommend cancerous lesion or high-grade dysplasia for underwater EMR because underwater EMR's merging is a little bit vague. So I do not do underwater EMR for those lesions. And lesions more than 20 millimeter, is yeah, very exceptional. Don't do underwater EMR for those lesions. And the third question is, yeah, yeah, there are a lot, some of lymph node metastasis risk factors, which is mentioned in our guideline. Yeah, first is, yeah, as you said, invasion length, more than 1 millimeter. However, recently, lesions with only invasion length more than 1 millimeter and without any other risk factors has a very low possibility of lymph node metastasis. So lesions with only invasion length more than 1 millimeter, we now observe those cases without surgical operations. However, vascular and lymphatic invasion, yeah, its lymph node metastasis rate is 20%. And tumor budding, yeah, small tumor cells on the bottom of tumors in the submucosa, it's also high lymph node metastasis rate. It is reported as 30%. So lesions with those factors, we strongly recommend surgical operations to the patients. Thank you. Thank you very much. Yep. For screening program, yeah, we only use regular colonoscope because artificial intelligence is not so spreading in Japan. It's a beginning of the stage. So in the future, I recommend these things to colonoscopists, endoscopists in Japan. However, now it's in the beginning, and also it is a little expensive. So we have yeah, such issues for spreading AIs. However, in the future, yeah, some of my friends, my expert Japanese endoscopists, try to get insurance medical fee about AI. So I think it will be succeeded in the future. If so, AI may be spreading in Japan.
I'm sorry, Sensei.
It's okay.
I had a problem, a technical problem here. Well,
okay.
The question, what's your tips, tips or tricks to a good accuracy for diagnose differential diagnosis between neoplastic lesions or non-neoplastic lesions?
Oh, yeah. Yeah, we use BLI or NBI for all cases. And we also use magnified endoscope for all cases. So we immediately magnify a lesion, especially, not only for experts, but for young doctors. Yeah, I educate young doctors to use magnify endoscope for every cases. So they use yeah, BLI magnification and NBI magnifications for differentiating neoplastic lesion to hyperplastic polyps.
Yeah. One more question, please.
Thank you.
And
Please.
And it's easy to learn about magnification and capillary pattern analysis.
Learning Kaplan. Yeah.
Is easy or not?
I don't have those kinds of analysis for learning, but yeah, it seems very interesting. So I try to do those studies in the future. Thank you very much.
Okay, so I start. So again, thank you so much, Sensei. I also thank the organizing committee. It was excellent seminar. And it's so nice to see that you have presented to us a very complete approach from diagnosis to treatment, from basic treatment and advanced treatment. My question for you, final question is, when you receive a patient referred from another hospital, like a LST lesion for potentially for an ESD procedure, do you first perform your own colonoscopy to study the lesion, to assess the lesion, and to plan the endoscopic intervention, or you schedule the patient straight for the ESD procedure? How is the protocol in your center when you get referrals from different hospitals? Thank you.
Yes, thank you for your good question, Dr. Arantes. Yeah, I do pre-check colonoscopy by myself to refer the patient because in previous hospitals, endoscopic manipulation was not evaluated regularly. But regarding ESD, scope operability is very important factors. So we have to check it in a pre-check colonoscopy. And also, sometimes in previous hospitals, they don't have magnifications. So sometimes advanced cancer is referred to our hospital for ESD. So we have to check about the tumor characteristics in our unit. Thank you very much.
Thank you again for sharing your knowledge to us. It's very important for us to listen to you. You know, I have many times I ask you to help in some cases, and thank you.
Yeah, it's okay.
And now I use in my routine colonoscopies LCI to withdraw the colonoscope in all cases. I don't use more white light. What do you think? Do you think we have to move from white light in all colonoscopies that you're doing?
It's a very good question. Thank you. Thank you, Rix. Yeah, I think LCI has is too bright in some parts, especially on the angle, hepatic fracture or splenic fracture in the sigmoid descending junction. So for those areas, endoscopic monitor becomes too bright sometimes. So it may affect polyp miss in LCI. So now we don't use these parts with LCI. But for regular area, for straight area, LCI is very useful for detecting polyps. So I recommend LCI mainly However, in some parts, please change it to BLI or white light imaging for detecting more polyps. Yeah, but it's my opinion, my own opinions. So we have to prove those things in the future. Thank you, Rix.
One question, Yoshida-sensei.
Yeah.
What's the barrier to detect cell-saturated lesion? BLI or LCI?
Yeah. Yes, thank you, Carlos. Yeah, it is very challenging. Sometimes BLI is better than LCI. I found those lesions, but in some regions LCI is better. So I don't have accurate comments for the questions. However, for right-sided colon, so please use LCI and BLI both. If the preparation is good, I recommend BLI. BLI is good for SSL. However, in some cases, 25% or more cases, it has poor preparation. So we have to use not BLI, but LCI for those cases. It's my opinion. Thank you very much.
Thank you.
IBP and Promedon. So to close, once again, thank you for your presence. Your certificates of people registered will be sent by email. And here I close the second international seminar on digestive endoscopy. Thank you all.
Thank you. Thank you, Rodrigo. Thank you, everyone. Bye.